So, right, we do have Dr. Christiana Onisiforou in the house. She was born in Washington, D.C. and grew up in her hometown in Limassol, Cyprus. She obtained a Doctor of Dental Medicine degree in 2019 from Semmelweis University in Budapest, Hungary. In pursuit of her further education and training, she moved to Ann Arbor, the University of Michigan, to join the Graduate Prosthodontics Master Program at that university. During her 3-year training, she gained experience in treating several complex full mouth rehabilitation cases, focusing on all phases of oral rehabilitative treatment, including implant placement. And she was awarded 2021 to 2022 Ed Billy Graduate Scholarship Award for Excellence in Prosthodontics. Upon completing her specialty training, she has returned to Cyprus, where she's working as a prosthodontist in a private dental specialty clinic. She's a member of the American College of Prosthodontics, the European Prosthodontic Association, and the Cyprus Dental Association. Dr. Christiana Onisiforou, is a great privilege to have you on Dental Webinar Series. How are you?
I'm good. Thank you for having me. I'm going to start my screen sharing. Okay. Okay, so thank you so much for having me. I'm really excited wherever you're in the world. My name is Christiana Onisiforou, and for the next, so we'll be talking about full mouth rehabilitation. So we'll start off with a little bit about me. I was born in my hometown of, I was born in Washington, D.C., but raised in my hometown of Limassol, Cyprus. It is the third largest island in the Mediterranean, and we have 320 days of sunshine per year. I graduated from dental school in 2019 and moved to Ann Arbor in 2020 to join the Graduate Prosthodontics program at the University of Michigan. That's a photo of me and my family at my graduation last year. A little bit about them. My dad is a prosthodontist and periodontist, and he has a successful private practice in Limassol. My brother is a second-year pros resident at U of M. So we're a family of dentists, except my mom. So after graduation, I moved back home to join the family practice, where I'm currently working as a prosthodontist. So as a prosthodontist, planning and executing the restorative rehabilitation of a decimated occlusion is probably one of the most intellectually and technically demanding tasks, and the undertaking of a full mouth rehabilitation should not be taken lightly. The stakes are high, and failure is costly, and treatment planning decisions should be based on scientific evidence, which is why we'll be discussing and I'll be walking you through step by step. So the outline of my presentation, we'll start off with assumptions of what are indications and contraindications of a full mouth rehab. A large group of individuals that require full mouth rehab have worn dentition. So we need to know what are the etiologies, how do we classify it? We will talk about vertical dimension. How do we evaluate if there has been loss of vertical dimension? How do we raise it? Why? And then we'll talk about diagnosing, treatment planning, and sequencing of a full mouth rehab. Do we start with anterior teeth first or posterior teeth? We will talk about occlusion, the different philosophies, what is anterior guidance. I will share with you a case of mine, and we'll end with some take-home messages. So let's get started. So people People are frequently judged by their looks, and this can shape how others perceive their character. So a beautiful white Hollywood smile is usually perceived as a source of joy, confidence, and beauty. However, if someone has unhealthy, yellow, damaged, or missing teeth, their appearance alone will lead to unfair assumptions about their personality. This underscores the importance of comprehensive dental care and the role of prosthodontics in restoring both oral health and confidence. So full mouth rehabilitation in prosthodontics, it offers individuals with dental issues a chance to regain not only their smile's aesthetics, but also the functionality of their teeth, ultimately reshaping how they are perceived by others and enhance their overall well-being. In the glossary of prosthodontic terms, full mouth rehabilitation is defined as the restoration of the form and function of the masticatory apparatus to as near a normal as possible. So in this photo, you can see a lot of things going on. We have loss of vertical dimension, collapsed bite, missing teeth, worn dentition, over-eruption of teeth. So we can suspect likely they'll need a full mouth rehab. So we cannot talk about full mouth rehab and occlusion without mentioning, of course, Dr. Dawson, known worldwide for his contributions to the fields of occlusion and restorative dentistry, as well as his concepts on the diagnosis and treatment of temporomandibular disorders. He said that patients lose their teeth in two ways: the teeth break down or their supporting structures. Another definition that we need to know is occlusal rehabilitation. It is defined as the restoration of the functional integrity of the dental arches using inlays, crowns, bridges, and partial dentures. So what are the reasons for undertaking occlusal rehabilitation? I already mentioned a few, but they are to obtain and maintain the health of periodontal tissues, to replace missing teeth, worn down teeth, or old restorations, to improve aesthetics, to eliminate pain and discomfort of teeth and the surrounding structures, to restore impaired occlusal function, and preserve the longevity of remaining dentition. So regardless of the clinical reason, the decision to carry out any treatment should be based upon achieving the reconstruction, restoration, and maintenance of the health of the entire oral mechanism. So the teeth, the periodontal structures, the muscles of mastication, the temporomandibular joints, should all function together in harmony. So are there ever any contraindications to doing a full mouth rehab? There are actually many malfunctioning mouths that do not need extensive dentistry and have no joint symptoms. These cases are best left alone. Prescribing a full mouth rehab should not be taken as a preventive measure unless there is definite evidence of tissue breakdown. So the rule is no pathology, no treatment. So a large number of type of patients that require extensive restorative treatment are patients. So the first thing we need to know is what is the etiology. The first one is congenital anomalies, amylogenesis imperfecta, as you can see in the upper right-hand side. It is a hereditary defect of the dental enamel. It results in early loss of enamel and then subsequent attrition of the tooth structure. Dentinogenesis imperfecta, it's characterized by an amber-colored translucency of the dentition, and because of weakened attachment between the enamel and the affected dentin, the enamel wears away and exposes the dentin, which is then also subject to more attrition. The second reason is parafunctional occlusal habits. So the effect of chronic bruxism and other oral habits, if continued over an extended period of time, it leads to loss of tooth structure. Usually associated with emotional stress. Bruxism may be triggered by occlusal interferences. So counseling the patient to break these destructive habits, and also bite splitting therapy and some occlusal adjustments can be adequate if this is diagnosed early. However, if this has been going on for a long time, likely the teeth will require restorations. Another reason is abrasion. It is the wearing away of tooth tissue by external agents. An example is with toothbrushing. The gingival portion of the facial surfaces are worn away. The next one is erosion, as you can see in the bottom right photo. It's the loss of dental tissues by chemical process. So parts of the incisal edges or the palatal surfaces use popped out appearance, and the teeth do not occlude with the opposing teeth. So the acid that causes this wear can be classified as intrinsic or extrinsic, depending on the source. So either the stomach acid or from a diet. So, and finally, the last one is loss of posterior support. So extensive attrition of the anterior teeth often occurs when we lose posterior support by loss of teeth, malpositioning of teeth, occlusal interferences that drive the mandible forward, and this exerts undue force on the anterior teeth. So although loss of posterior support can result in anterior tooth mobility, sometimes it's not unusual to see extensive wear of the clinical crown of anterior teeth, but actually have their bone level is excellent and there's no periodontal disease. So that can happen also. So many patients do not realize the severity of wear and the consequences of delayed treatment. So in 1984, Turner and Msirlian, they placed these type of patients with worn dentition into categories relative to the occlusal vertical dimension. So before I go into all of the categories, I want to define vertical dimension. It is the distance between two points, usually the nose and the chin, and the difference between the vertical dimension of the face in intercuspal position and postural position, so the rest position is referred to as the freeway space, or today it's known as the establishment of an optimal vertical dimension of the face in prosthodontics is critical for the function of the stomatographic complex. So category 1, it is the excessive wear with loss of vertical dimension. And category 2, there is excessive wear without loss of the vertical dimension of occlusion, but there is restorative space available. And category 3, there is excessive wear without loss of vertical dimension, but there is restricted or no restorative space available. So it's commonly assumed that extensive occlusal wear will result in a decreased vertical dimension. However, there's no definitive evidence to support this concept. In my next few slides, I will we'll talk about how do we evaluate whether there has been loss of vertical dimension. Literature, however, is replete with reports that rehabilitation of an increased vertical dimension may cause problems. So we'll also be discussing that in the next few slides. So gradual tooth wear compensated by continuous eruption of the teeth, this maintains the occlusal vertical dimension. So we have loss of vertical dimension when the occlusal wear occurs more rapidly than the eruption. Okay, so how do we evaluate if there has been a loss of vertical dimension? We've already mentioned a few. So the first one, posterior support, it's the most common cause of decreased vertical dimension. history of wear. We mentioned it already, phonetic evaluation, both Pound and Silverman, reliability of the speaking space as a method to determine occlusal vertical dimension for complete denture patients. So what does this mean? They basically they compare the relative position of the anterior teeth during the formation of the S sound. So the normal mandibular position during the S sound places the incisal edge of the mandibular incisors 1 millimeter inferior and lingual to the incisal edge of the maxillary incisors. So if this vertical positioning is more than 1 millimeter apart, then this may indicate that there has been loss of vertical dimension. The next one is interocclusal distance. So it should be emphasized that these measurements, it might not be the best way to see whether there has been loss of vertical dimension, but that looked at 200 patients with excessive wear, and he found that 83% of these patients had an interocclusal distance of 3. And no patient had an interocclusal distance of more than 6 or less than 3. So, but I do emphasize that these are just measurements and guidelines, and it might not be the same for all patients, and good judgment should prevail. And the last one that I want to talk about is facial appearance. The external appearance of facial tissues and musculature should be carefully reviewed if loss of vertical dimension is suspected. So diminished facial contour, thin lips with narrow vermilion borders, drooping commissures are usually associated with overclosure. However, wrinkling, loss of facial contour are normal ages, and the temptation to restore a youthful appearance by increasing vertical dimension is not a good idea. So raising vertical dimension, we need to know why do we do this? And there are 3 reasons. It is for aesthetics, for restorative space, and to level the occlusal planes. So what is the effect of raising video? There have been a lot of studies actually that look at this, and to see whether can we adapt to vertical changes and how much. So one study that I want to share with you is by Carlson. He studied the effect of increasing the vertical dimension by looking at the electromyographic assessment of muscle activity. So splints were placed covering the canines, premolars, molars to increase the vertical dimension by 4 millimeters in the incisors for 7 days. So you need to know, have in mind that when you increase the vertical dimension by 4 millimeters in the incisor region, it is increased by half of it, 2 millimeters in the posterior region. So they looked at the EMG recordings of the temporal and the masseter muscles, and they found that after removal of the splints, the resting face height diminished and the interocclusal distance remained greater than before. Most subjective symptoms disappeared after 1 to 2 days. Overall, the muscle activity decreased over the 7 days, and we can conclude that overall, the procedure for increasing vertical dimension, we are able to adapt to these changes, and provided that occlusal stability is achieved. So this was with 4 millimeters of raising the video. Another study that I want to share by Helsing, again, was also done with the use of occlusal splints. And they also found that they raised the video by 6 millimeters. The jaw muscle tonus can adapt to extreme changes in vertical dimension in just 1 closure. So tooth contact is critical. As soon as the mandibular teeth come into contact, the periodontal receptors are fired, in the mesencephalic nucleus, this activates the reflex arcs that will bring about this adaptation. So both these studies that raised the vertical dimension in the anterior region by 4 to 6 millimeters, the patient were able to adapt. So we've talked about a worn dentition and vertical dimension. Now we will talk about diagnosis and treatment planning and sequencing a full mouth rehab. So what do you do when a patient presents to your office for the first time? So we need to collect all of the data to be able to give a diagnosis. So the first thing is collecting the patient's medical and dental history. Of course, the dental examination, radiographs, panoramic x-ray, as well as a full mouth series. Also photographs, both extraoral and intraoral photos. We can find out a lot of information from extraoral photos, for example, by looking, we can see the lip support, also when they're smiling, if the patient has a high smile line. So it's very important to look at everything. We need to do a diagnostic mounting. So we need to have study casts that are mounted in CR. And then on that, we do a diagnostic wax up. I will talk a little bit more about that in the next few slides. So after collecting all of this data, we use all of this to come up with a treatment plan. So prosthodontists are the leaders of the treatment plan. So they're the ones that coordinate everything. If any other specialists are needed, if you need a periodontist, endodontist, they help with the coordination of all of this. They ensure that the treatment plan is communicated to the patient. And especially I take this very seriously with my patients to talk to them, and because this is a long process, takes about 2 years, up to 2 years, depending on the case. So I like to let them know exactly what I will be doing. So it's very important to have a good communication with your patient. And then the treatment plan is divided into the pre-prosthetic phase. So that includes the disease control phase, if you need any extractions, then if you need any perio consults or anything else is done. Everything else is done before the prosthetic phase, which is divided into the provisional and the definitive restorations. And finally, the maintenance phase. You see the patient after 1 month, 3 months, 6 months, 12 months, and yearly afterwards for follow-ups. So now I want to talk about the sequencing of a full mouth rehab. We start with anterior teeth, posterior teeth, and the answer is anterior teeth should be done first. And this is critical because we want to establish the anterior guidance and the incisal edge position first. The interaction of the anterior teeth are critical in speech and phonetics. In addition, the aesthetics of the case are determined by the height of both the maxillary and the mandibular anterior teeth. And also the anterior teeth, basically to establish also the level of the occlusal plane. So what are the 4 determinants of they are aesthetics, phonetics, condylar border movements, and the relationship of the maxillary and mandibular anterior teeth. So this is where the diagnostic wax-up comes in to place. Speaking about the morphology, so accurate palatal surface morphology of the maxillary anterior teeth is critical for establishing the incisal guidance. So if you have a compromised anterior guidance for long durations, this can initiate abfraction or attrition, we'll start having issues with the TMJ, so also an extreme vertical overlap associated with an exceptionally steep incisal guidance can be relieved by an increase in occlusal vertical dimension if it's indicated, or sometimes we can reduce the incisal edges of the lower anterior teeth. So why is anterior guidance so important? And I want to share with you the article by Williamson and Lundquist, very classic article. They said that only when posterior disocclusion is obtained by an appropriate anterior guidance can the muscle activity of the temporal and masseter muscles be reduced. So we want to have anterior guidance, and also in lateral excursions, canine guidance to have separation of the posterior teeth. And it is not the contact of the canines that decreases the activity of these muscles. It is the separation of the posterior teeth. So there has been a search for the ideal occlusal scheme to be followed during a full mouth rehabilitation, and to be able to have an optimal muscle and joint function and an ideal occlusion that doesn't wear. So I want to talk about two philosophies that exist on occlusion. The first one is the gnathologist approach by Charles Stewart. He believed that centric relation and centric occlusion are equal. That point-centric contacts are ideal, and that cusps occlude in the fossa as a tripod. And so on the way to contact, there should be no occlusal interference or guidance. And at contact, any sideward or forward movement requires immediate opening. So the posterior teeth should separate to achieve a mutually protected occlusion. And of course, they believe that condylar movements in the fossa dictate the morphology of the position of the cusps. The other philosophy is by Pankey and Mann, and they believe that there should be freedom in centric. So the cusp tip touches the fossa, and there can be a slight movement inside centric occlusion. So CR and CO are not equal. And they also believe that the lingual surfaces of the maxillary anterior teeth are independent of the condylar border movements, and they are dictated by the need for a long centric through the use of adjusted provisionals and a wax up. So the aim of both techniques is the same, to basically achieve precise restorations that need minimal adjustments when seated, and that is the goal in a full mouth rehab. So the only difference is that they capture the envelope of motion using different methods to achieve the same objective, and they have these two categories of occlusal philosophies. So now I'm moving on to the second part of my presentation. I want to share a case with you. So hopefully this will help tie in all of the theoretical things that we've discussed and help it make more sense. And we'll go through all of the steps together. So my patient, she's a 76-year-old female, presented to the clinic with chief complaints. I have trouble chewing ever since losing fillings and tooth structure. The patient's medical history was reviewed. So she has high blood pressure, irregular heartbeats, and heart murmur. She has hypothyroidism, skin cancer, arthritis, and lymphocytic colitis. She reports she suffers from seasonal allergies. She's allergic to penicillin, sulfa, and ciprofloxacin, and she reports she has a mild form of von Willebrand's disease. So her medications include, for high blood pressure, she takes spironolactone, amiloride, and triamterene, which are potassium-sparing diuretics. She takes levothyroxine for her hypothyroidism. Her supplements and vitamins include potassium, zinc, and boron. And she also takes elderberry and quercetin, which are antioxidants and anti-inflammatory medications. And for her frequent migraines, she takes Excedrin. So we start with the extraoral photos. Keep in mind all of the things that I spoke about earlier. So with the extraoral photos, we have the examination of the head and neck region, complete, no cervical lymphadenopathy, no palpable lymph nodes, no muscle tenderness, and no thyroid abnormalities. Examination of the TMJ, there was no clicking and no popping. No deviation upon opening or closing was noted, and there were no facial asymmetries. Looking at her side profile, she has a convex facial profile. Now moving on to the intraoral photos, soft tissue examination, no pathology associated with the lips, tongue, buccal mucosa, floor of the mouth, or the oropharyngeal tissues. Her dental history revealed that she had her wisdom teeth extracted. She reports some of her teeth are sensitive to pressure, and she has trouble chewing ever since her teeth started. From my examination, there was of her TMJ, there was no clicking or popping. She did tell me that she does have some muscle tenderness and soreness, especially on her right side. And she has previously used a bite splint. And other previous dental care includes, as you can see, large amalgam restorations. She has a crown, some composite pin retained restorations. This is the protrusion in frontal view. So also I have photos of during all of the movements. Protrusion right and left side. Medial protrusion right side and lateral protrusion right side. And the left side. This is the maxilla from the occlusal view. Again, you can see like the close proximity to pulp, large amalgam restorations, and also the mandible from the occlusal view. Panoramic X-ray is very important to take a look at the condyles. Her condyles look symmetrical, and also the full mouth series. It's important to see, we can see if there's any periapical pathologies, if there's any bone loss. And so once we've collected all of this data, then we move on to the mounting. So impressions of the maxillary and mandibular arches were done and poured in type 3 mounted on a semi-adjustable articulator. A face bow was used to transfer the maxillary, the maxilla, yeah, and also the bites was done with centric relation. And you can see that the patient is a class 2. And so on these models, that's where you start to do your diagnostic wax up. So the diagnostic wax up is done at the new vertical dimension. So as we said, we open the vertical dimension for aesthetics, for restorative space, and to level the occlusal planes. So I actually do it arbitrarily. I just open the pin as an estimate, what I think that I will need to create a nice occlusal anatomy. And once the incisal edge position is determined, I also look at the ideal width to length ratio of the central incisor, which is about 80%. using the principles of the golden proportions. So then the rest of the teeth can be waxed up. And the diagnostic wax up, of course, nowadays it can be done in a digital way, but it's also a very good way to communicate with your patient and explain to them what you'll be doing. So my patient, her diagnosis, so we collected all of the data, and now we can have a diagnosis. She's classified as a ASA 2 patient. She has occlusal wear of the teeth with involvement of the dentin due to attrition from parafunctional habits and bruxism. So the treatment plan was a full mouth rehab with full coverage crowns. So now I will walk you through all of the steps that I did. So first was the core buildups on numbers 4, 15, 18, and preparation and temporization of all the teeth was done. Then prophylactic endo treatment was done on number 3, 19, and 20. Prefab post on number 3 and 19, and the cast post and core on number 20. The next step is refining the preps and scanning for lab provisional restorations. So actually I had 2 sets of provisionals in this case. The first set was done chair side from my diagnostic wax up. And then here is the scanning for the lab provisionals. There's a pre-treatment scan is with the then retraction cords placed. The anterior maxillary and mandibular teeth are scanned first, and then the posterior right and left sides, and the bite is taken with the provisionals out first on the right side and then the left side. After that, the patient gets the lab provisionals. So this is the delivery of the lab provisionals. They are in bridges, so they're sectioned bridges from 2 to 5, 6 to 11, 12 to 15, 18 to 21, 22 to 27, and 28 to 31. These were milled PMMA, and they were tried intraorally and relined at any deficient margins, polished and cemented. So then the patient was sent home to try her new teeth and give us feedback at the following appointment. Of course, I checked for any occlusal interferences, checked anterior guidance for the separation of the posterior teeth, using all of those that I mentioned before, having all of those things in mind. The only thing that she, when she came back, her comment was that she was struggling a little bit with speech, and that she found like her anterior teeth were a bit too long. So they were shortened, and she went home to try them again. This is the provisional phase is the most important phase. We have to ensure that the patient is able to talk and eat. And she also told me that she was because she had issues with her TMJ. She told me already that she was feeling her muscles more, she wasn't having any more pain. So this is a crucial phase to make sure that the patient is not getting worse, but actually when they give comments of positive things, then it means that you're moving in the right direction. So so once everything is okay, then we can move on to the final restoration. So I like to do it in 2 phases. The anteriors first. So the vertical dimension is held by the posterior provisional restorations. The upper and the lower scanning is done. And then in the next appointment, there is the delivery of the anterior teeth. Again, we check for anterior guidance, canine guidance, and lateral excursions. And if everything is okay, then we move on to the scanning of the posterior teeth. and the delivery of the posterior final crowns. This is maximal intercuspation, right and left side. Again, I take photos of all of the different movements. So in protrusion, we can see the separation of the posterior teeth, maxilla occlusal view, and the mandible. At the end, again, you have to take all of the x-rays. This is the final FMX, and this is the final result. So the before and after. So actually, yeah, the case turned out very, very nice. The patient was very happy. She looks 20 years younger, and so we were able to give back her smile. So not only aesthetically, but she was able to function again. So that's the case. I want to, we're reaching toward the end of the presentation, but I wanted to say, talk a little bit about digital versus conventional. As you can see, this case, I did both conventional and digital. Well, actually, it was mostly digital. The conventional was the study cast and the diagnostic wax up, but the rest of the case was digital. And it's important to know where there are possible errors that might occur, and also every day there's so it's important to always read on any new products that come out. And so I wanted to share two articles. So intraoral scanners, what could be the errors? So they lack a fixed reference. So the first image taken by scanner, it's used as the reference, and then all the subsequent images are sewed onto the previous image. So a larger scanning area will require more images sewed onto each other, so ultimately will result possibly in more errors. So one way that we can reduce these errors is by trying to not do a cross arch scanning, and do, for example, the right side or the left side, or anterior, posterior. So this is one way to try to reduce the number of errors. So the study by Zhang, they looked at 3 different intraoral scanners, the Omnicam, Trios, and iTero. There were different numbers of crowns and abutments, single, anterior, posterior. They looked at half arch, cross arch, spanning, and they found that an increase in the scanning length leads to a decrease in the scanning accuracy, particularly with respect to a full dental arch. And they found that most of the errors were located in the incisal edges of the anterior teeth, and also distal end of the at the end of the dental arch around the second molar. So and then the other study by Renee, they looked at the relationship of sexton and complete arch scanning accuracy, and they found that scanners differ regarding the speed, trueness, and precision of sexton's scans. And the scanners were plan scan and the CEREC one, they found that they had the best combination of speed, trueness, and precision for the sexton scans. But for the complete arch scans, the scanner that had the best results was 3Shape. So restoring a patient to physiologic health is a challenge that requires the clinician not only to be a good diagnostician, but also to be able to master a wide range of treatment modalities. So every patient is different, every case is different. We have to be able to adapt to all the cases, but still knowing all of the basic core theories and philosophies which I mentioned to you today. So the key to a methodical approach is to have a correct diagnosis and a treatment plan. So collecting all of the data, also evaluating the etiology, the history, and factors relative to occlusal vertical dimension are also essential to treatment planning. And also deciding on the sequence of your treatments and sticking to it. So also you have to decide what occlusion is best for the needs of your patient and to be able to achieve that. So a comprehensive study and practical approach must be directed towards the reconstruction, the restoration, and the maintenance of the health of the entire oral mechanism, which I've said a few times in this lecture, but it's very important that we look at the entire mechanism. So that's the end of my presentation. Thank you so much for your attention. And if anyone has any questions, I'm happy to answer.
All right. Thank you so much, Dr. Onisiforou, for that wonderful presentation. I do see a couple of our friends here all the way from Michigan. Go Blue, everyone out there. I see my friend from Portugal. I see folks from Costa Rica. I see people from Norway, from India. Oh my God, Dr. Onisiforou, how did you pull this together? Everybody is here from around the world. I can see folks from Ghana, Nigeria, Norway, California, Iraq. The whole world is gathered for you, Dr. Onisiforou. Such a powerful presentation. We do have, if you have some questions, okay, let's see. Do you have a question there? All right, Anna, I can see you. I'm going to allow you to talk. We have a case coming up, and I would like for us to chip in. I'm going to put up that case shortly. Okay, can you see this? Can you see that case?
Yeah. Oh, wait, yes, I can see it.
Okay, all right. So this is a patient that showed up. One of the residents in our facility has this patient, and the patient came in, with this, cover-up veneer type thing that the patient had on. I'm going to show. Let me just play screen. You can still see it.
Yes.
Okay, so this is how the patient is. I don't have any radiographs here, but I just can, we'll use what it is for us to just go through this case and see how we can just use what you have given to us. You have given us etiology. You need to find out what is going on first, in terms of all the whole 9 yards that you just put out, quite detailed in terms of how to approach every case. So people want to jump in and start doing stuff. Like you said, you want to gather information. I want you to go through this case for us, just using the template that you have prescribed in most of your cases in trying to determine how you want to approach the case. And if anybody wants to chip in on this, please go ahead. But Onisiforou, please go ahead and see how do you want to get started with this case.
Okay. Yeah. So the first, of course, is the diagnosis. Collecting all of the data. I can see you have like some good intraoral photos. We need to know. I also did the patient have some temporary restoration?
Yes. So the patient had something on there. Yeah. So just to cover it. So there was like a pop-up type of thing. It was not cemented.
Okay.
Just yes.
Okay. Yes. So it's the methodical approach. So collect all of the data, gather all of the information, devise your treatment plan. You want to think about the sequence. Are you going to start? Well, they should know by now that we start from the anterior teeth for all the reasons that I explained already today. And about the provisionals, so if the patient is provisionals are done in the anterior region, so we'll have to open the vertical dimension. to, as you can see, the occlusal plane needs to be, we need to level it. We want to improve the aesthetics and for restorative space. So we will be opening the vertical dimension, and you'll determine how much that will be first set of, and if you start, so usually I do the anterior teeth first, and in this new vertical dimension, so the posterior teeth will be open, so you can use composite buildups to get contacts in the posterior preps, and but usually it's just for a few days in between these two appointments, so the patient won't be in the like that for too long.
So quick question.
He'll go home and tell us. Yeah.
So for this case, what do you think the diagnosis is? I mean, obviously we don't have enough information, but do you think it's a case of amelogenesis imperfecta?
Could be.
Okay, so
did the patient have any? Did they think about their genetic? Do they have anyone else in the family that has the same?
Yes, probably. So in that case, is the treatment plan different in terms of, is it the same thing in terms of bonding to dentine since his enamel is coming off? Do you think that because
yes, for sure. This patient, there will be issues with bonding. So it will be single crowns. So full coverage crowns will be the final restoration for this patient.
Okay. Yeah, please go ahead. Go ahead. So you will follow your, I'm sure we'll go back. So guys, if you're looking at this case, you want to go back to her presentation.
If anyone else wants to join in.
Dr. Caracho, are you there? I can see you're there. You're able to speak if you want. Please go ahead. I know you've done a couple cases like this before.
Hello, I'm here.
All right, all right.
I miss
hear
you
your
guys.
voice.
How are you?
I'm good, I'm good.
No, but Christiana is going great. No, nothing to say. Follow through.
So what would you do with a case like this?
No, the only thing that I was thinking, exactly like Christiana said, whatever she was talking about in the presentation. The interesting thing is that if the patient is using those already, it seemed like, you know, he was already with his vertical opened a little bit, so he's only missing the posterior stops, which might be something interesting to give him. So, you know, to stabilize the position of his joint in the back, so before moving to the finals, right? So maybe he will stay a little bit longer in those stems. But yeah, looks like a straightforward case. The only thing is,
do you think you're going to do any extractions in terms of, you know?
Yeah, that's the only thing. Yeah, the only thing that I was thinking about is then you'd have to see the X-rays and do the wax up to see if you could use these teeth, especially the posteriors, right?
Yeah, they're right in the nerve. So would you do a root canal?
Yeah, if you want to try to use those, oh yeah, a root canal, I would do a root canal to avoid problems in the future for sure. But I don't know if they're going to have trouble, but who knows?
Yes.
Maybe, yeah.
And also, you know, so the gentleman was saying that, you know, in our clinic, these kind of cases, we take out all the teeth and we give them some all on 6. What do you think?
Yeah, that was one of the things that I went to the US that was kind of like surprising for me, but I understand because it's very expensive treatment as well, especially in the US to do root canals on teeth. And sometimes it's cheaper for the patient to do that. But I mean, we know that if you are able to keep your teeth, right?
Yes.
It's always better. So yeah.
Anyway, you guys are the Europeans and you guys are quite conservative.
Hey, that's the thing. That's why.
Americans are taking out teeth. You know, I think, you know, from what I see at work every day, you know, once you take out teeth, you are creating a cripple, you know, because there's really nothing you can do. Dentures or whatever you do, you know, it's better to Try to keep your teeth as much as possible. Dr. Onisiforou, there's a question here that says, in situations of, I guess it's the same question here by Dr. Cyrus Micah, how do you deal with the impacted teeth in full mouth rehabilitation? If there's some impaction along with it, I don't know if that question is framed correctly.
I guess, yeah, they didn't say, are they talking about the wisdom teeth or which teeth? In this case, it doesn't.
Okay.
We have to see the X-rays to see if there's any heights them. But
all right.
Yeah,
hold on. Somebody's.
We need to see like the radiographs.
All right. Somebody, Dr. Akiade, you're right there from Nigeria. She's a U.S. trained dentist who is currently working in Nigeria. Dr. Akiade, please go ahead. You have a question. Dr. Shade, you are able to speak. If you would go ahead. You can unmute.
Okay. Yes, good evening. I'm so sorry I came late. I joined the meeting late. But the bit I heard was very interesting. Thank you, doctor. Yes, I had a few patients like this. One in particular had a radiation therapy in England. And by the time I saw him, his lower teeth were totally all the way to the gums. And after getting all the reports, the X-rays and everything, he had removed one tooth after the radiation therapy. So he had what's this called again? Anyway, they ended up having to opening this, having a communication with the sinus, but we were able to rehabilitate him and he was able to chew. But we had to use a lot of fluoride treatment. Almost every 2 weeks, he was coming in for fluoride treatment. And what else? We did root canal therapy on practically all the front teeth. And the posterior teeth, we ended up just crowning them without reducing the occlusal level. I see.
Oh, all right. So that comes in as well with radiation. But these cases, they come. So we're going to be able to put some cases together to discuss. I believe as you see these things for prosthodontists, they do a lot of multiple crowns, multiple preps. So it takes quite some skill in trying to do that. Obviously, there's so much more we could discuss today. We do have, we're meant to have another presentation by Dr. Anastasaki, but that we have moved to the 17th of March. She's going to be with us. She had an emergency earlier in the day, and we had to move that appointment. And next week on the 16th and on the 17th, we do have Dr. Leroy Houghton, surgical therapies for implant therapy and material considerations in full out prosthesis. I mean, she's doing fantastic work. Dr. Houghton is a periodontist in training at Oregon, and we also have Dr. Ola is a prosthodontist doing amazing work in the Texas area. Dr. Onisiforou, it's been a wonderful time having you. Thank you so much for giving us of your time. Thank you all for joining us. And for those in Nigeria, we are looking forward to starting implant clubs. Every city in Nigeria will have an implant club. So if you want to join us, that's the resource on the screen. Dr. Onisiforou, do you have any last words today?
Send me a message on Instagram, answer and go through. That's all. Thank you so much for joining, everyone. I hope you enjoyed it.
Yes, we sure did. Thank you so much. It's been a wonderful time. I did have a pleasurable time, and looking forward to more times with you, Doc. Obviously, we're going to be in Cyprus one of these days to see you do a case live, and we're going to bring our cameras.
Yes.
Your clinic. And Dr. Ana Caracho is going to join us all the way from Portugal. We're going to make that happen. Let's have a little bit of some reunion time with all the guys from Michigan here. I can see all the other doctors in Ghana. Thank you so much, Dr. Onisiforou. I really appreciate this. Obviously, this is going to be recorded, so I'm going to put it out. It's on Facebook if you want to watch it. I think you should go back because the articles are there. For me, I'm going to be stopping every screen. You know, I'm going back to all those. Those are the classic articles that you should have in trying to explain things. You know, as you were speaking, I was hearing Dr. I was hearing our professor right there.
Beard, yeah.
Dr. Bien, I could
Yes,
just feel him.
always.
The spirit of Dr. Bien was right here with us. He's such an amazing teacher. Anyway, thank you so much. You guys have a wonderful rest of the evening.
Thank you.
Right.
You too. Bye-bye. Bye.
Bye.
All right, so looking forward to seeing you guys. If you're holding on, we're going to be with Dr. Horton on the 26th, on the 17th, and on the 16th, and we also have Dr. Anasasaki who will be joining us then as well. Looking forward to an amazing time